Right? Anatomy, about the angle. We mentioned that the only way we can see the angle is gonioscopically. So Van Herrick's a good rough guide, but it's not gold standard. So, glaucoma is very straightforward. It's all about how much fluid is produced in the eye and how much fluid leaves the eye. If we did not have fluid inside our eye, the eye would deflate like a balloon. The majority of the fluid in the eye is the vitreous cavity, but at the front of the eye, the anterior chamber is aqueous, the pure aqueous fluid. Where that leaves is where the iris meets the outer dome called the cornea. It forms an angle. Who's someone like me who's short-sighted? The angle is very deep. What does the angle contain? All the structures we've already spoken about. The trabecular meshwork, Schwalbe's line, ciliary spurs, ciliary body, etc. So, when the angle is deep, no problems, and we know that from gonioscopy, and then we can put a Zen in, we can put an iStent in, we can put cyclops in. But what happens if the angle is narrow? We cannot do any MIGS, so we'd have to take out the lens and do an ECP, for instance. But in these patients, problems occur sequentially. So this is an evolutionary stage. If your angle is narrow, it goes through these three processes. Primary angle closure suspect. The angles are occludable. So within 180 degrees on gonioscopy, the iris blocks the view of the trabecular meshwork. So when you look on gonio, you cannot see much of the angle in at least 180 degrees. Then it evolves to primary angle closure, which means you cannot see the angle in 180 degrees, plus the pressure is raised, or you see sticky bands forming, peripheral anterior synechiae, PAS. Then finally, you have all of these three things, plus glaucomatous opticopathy. So you get PAX, PAC, and PAC-G. This PAC-G is more visually significant than open angle glaucoma. So you are more likely to go blind with primary angle closure than open angle glaucoma. And who gets this bad? Asians and Afro-Caribbeans. The problem with having narrow angles, not only do you get PAC-G, but you also get angle closure. So you admit patients with, in casualty, you see angle closure. Why does that happen? The angle closes completely. There's nowhere for that fluid to go. The pressure goes up. And what do you need to do? You need to stop pupil block. So we'll go on to pupil block. This is probably the best diagram you're ever likely to see in your life. I just feel ashamed that I didn't draw it. so we talked about the angle. The angle is, this is the iris, this is the cornea. In between is the angle. Fluid is produced by the ciliary body. It goes retro, all the way through the pupil, retrograde, into the angle. That is normal physiology. Okay? What happens if you have a big lens? It pushes the iris forward, narrowing the angle. That's called phacomorphic. Okay, so when you've got a big fat lens, you need to take the cataract out. Otherwise, they're going to have problems with narrow angles. What happens if you have a small axial length, i.e., you are very hyperopic, or you're nanophthalmic, an axial length less than 19 millimeters? What happens is this space is already small.
How to prefer to take the lens of anterior chamber or posterior chamber in this kind of situation?
So, if you're going to, when you take out the lens, it's going to be exactly the same way. But where you put the lens tells us if it's ACIO, anterior chamber, or it's posterior, PCIO, posterior chamber. And so normally we put the lens in here. But if you damage the zonules, then you cannot put the lens there, otherwise it will move. It will either drop back or it'll move to the side and the vision will be obscured. Then you've got choices of where you put the lens. So in Oxford, we use a iris fixated lens, an artisan, or you can put an anterior chamber lens from here to there. You can leave them afake it, but then what's the problem with afake it? How long? Some people put the ACL on in the same time, so and the day of the surgery. The problem with that, occasionally you don't have this right size lens, or it's very, usually when that happens, the surgery is complicated, so you can get edema, corneal edema, so you can't see what's going on. Whatever you do, you must do a iridectomy. Why? Because if you've got a lens in front of the pupil, fluid cannot drain through the pupil because there's something blocking it. That's the case for a hyphema, that's the case for an ACOL, that's the case for a bubble in a DSEC, for instance, or DMEC. So you need to do something here, make a small surgical incision. That way, the fluid can drain from the hole you create and it pushes the iris back. So everything with a pupil block must have a PI and it will change. The other reason which we were alluding to is if you get uveitis, you don't get peripheral anterior synechiae. You can later on, but the first thing you see when you say, oh, the pupil stuck down, it's a small pupil, there is sticky bands from the iris to the lens that's stuck. So there's nowhere for the fluid to go. So the pressure goes up. So they get angle problems again. So again, you do a PI. In uveitis, if you do it with the laser, it closes. So ideally, you should do surgical.
If the pressure is still high after iridectomy, what do you do?
So you need to know why. If you have a situation whereby you've had a narrow angle for such a long time, and we've said that you can get sticky bands, which are peripheral anterior synechiae, not posterior synechiae, but peripheral anterior synechiae, you can get trabecular meshwork failure. The meshwork stops working. So in that case, you take out the lens to open the angle. After you've taken out the lens, if the pressure is still high, you suspect that there's been trabecular meshwork failure. So in that case, you do something surgical, whether it's a trab or a tube, depending on the etiology. Is that
A PI, does that then stand for phacomorphic with iridectomy?
So in phacomorphic glaucoma, the problem is that the lens has become too big and it's pushing the iris forward.
Yeah, it's just what does the abbreviation stand for?
Which one?
PI.
PI is peripheral, where have I written? Peripheral iridectomy.
Yeah.
Or iridotomy.
Yeah.
Iridotomy, because it's laser. Iridectomy means we cut it.
Okay. So,
Now, what I've said there is once you've done the PI, you must gonio afterwards. Okay, as a doctor, we must gonio, and if you guys are keen, I'm happy to
1
train
mirror
you.
or 3 mirrors?
It doesn't matter, because the only difference is one mirror, you just rotate it. So I use a 4 mirror because I'm lazy. But if you use it because you don't have to rotate the lens, but if you have a 1 mirror, you just rotate it. That's the only difference. The ideal person who should do the gonio is the person who gonioed before the laser. Okay, so if you've gonioed and you've seen that there's a narrow angle, it doesn't matter if you do the laser or someone else. In Oxford, the registrars do the laser. I don't do lasers here in my timetable. And then you re-gonio, and then you can see if the angle is opened. Now, up to 40 to 60% of people, 40 to 60% of people, after you've done a PI, do not open. The angle still remains narrow. Why? Because the reason it was narrow was not because of pupil block. It was not because of pupil block. There's some other pathology going on. Whether it's something here pulling. What could pull there? Well, if new blood vessels grow there, in rubiosis, they grow there, and initially it's a mechanical obstruction. So there's something over the pre-trabecular meshwork, it's before the trabecular meshwork, and it's a barrier for things for leading. Later on, they contract. They contract. So when someone says zipped angle, that's what they mean, that there's been something growing there, it's contracted, and everything's scarred down, so the pressure goes up. So if you do a PI, in that instance, it's not going to give help, because the pathology is not here, the pathology is here. So if you do a PI, fluid can go there, but there's nowhere for it to go. So that happens in things like rubiosis. It can happen in epithelial downgrowth, or ICE syndrome. So anything that goes there, blocks it, you're in trouble. So that PIs won't work. It can also happen if you've got a condition called plateau iris syndrome. What happens in plateau iris syndrome is these ciliary processes, they rotate forward. They push the iris peripherally into the angle. So even if you do a PI, nothing's going to happen because it's already rotated. So the only treatment is to re-rotate it back.
So can you diagnose that before you do a PI?
No, perfect, brilliant question. You cannot diagnose plateau iris until you've got a patent PI. You can see on going in to see this double hump appearance that you must have read about. You can do a anterior segment OCT or UBM or something, but ultimately you must do a PI.
So you go through stages of diagnosis. There's a rotation or something before you can.
Yeah. So for having a firm diagnosis, you have everything in life. Medicine is all about suspicion. You have to be Sherlock Holmes. Because you have a diagnosis and you think it could be right, it could be this, so you make a differential diagnosis and then you have to prove that right, whether it's imaging, whether it's CT, whatever, or whether to do a procedure to ensure that that's potentially, you formulated a preemptive diagnosis and you're proving it or dispelling it. And in this situation, it's to do with a procedure. Happy? Talked about that. Now, the only thing PIs do is to prevent angle closure. So that patient that comes into the ward with high pressures, needs an urgent PI and give Diamox, etc. That's the only thing it does. It does not stop chronic narrow angle glaucoma. So that's why a lot of my patients, we've gone away from doing PIs. What else can you do? Well, the EAGLE study has shown us that patients long-term, in specific situations, have less pressure, lower pressures, and less surgical interventions if you take out the lens. Because what happens when you take out the lens? You do clear lens extraction or cataract surgery, the iris flops back, the angle opens, and these patients do better long-term. The problem is that you're trying to maybe having to do surgery in a young patient with 6/6 vision, probably pre-presbyopic, so they've got accommodative reflex, with the risk of endophthalmitis 1 in 1,000. Plus they may need to wear glasses, and before they weren't wearing glasses. So you have to have a long discussion with your patient. And that's why sometimes when you're seeing this doctor, that doctor, this clinic, it's not great, because you don't have that kind of rapport with your patient, which is ideal in that situation. I have got videos for the surgery. Is that needed in this talk? Should we skip on? Yeah, skip on?
Yes.
Yeah, okay, no problem. So, second, let's have a quick break. You can stop recording, Susie.